So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening, everyone. Welcome to this evening's Lung Cancer Living Room. For those of you who may not know me, and I see a lot of new faces in the room, I'm Danielle Hicks. I am Chief Patient Officer here at GO2 for lung cancer. I've been doing this for about this is my 20th year. I just entered my 20th year, so I've been doing this work for a minute. I absolutely love getting up and coming to work every day. For those of you who aren't familiar with this programming, it was built with the person diagnosed with lung cancer and their families and caregivers in mind, where we bring to you live and in real time talks across varying aspects of a lung cancer diagnosis. Key opinion leaders like Dr. Velotta here. So Dr. Jeffrey Velotta is a thoracic surgeon from Kaiser Permanente in Oakland, and he is no stranger to this meeting. He has been here before, and we had a wildly successful meeting and a really important conversation. So we're really looking forward to doing that here again tonight. Dr. Millie is on her way. So we are going to scoot her right in around here. But we wanted to get the programming started for those of you in the room, and of course for those of you who are watching online. So welcome to everyone. Before we get started, we always sort of start with, I always tell people I could run through and sit here with my face in a paper and read people's bios, but instead I think it's more personal if you hear it from the horse's mouth. So Jeff, would you mind giving us a little intro and telling us how lung cancer became an area of focus for you?
Yeah, so thank you everybody for being here in person, so many people in person in July in the middle of vacation. So I am Jeff Velotta, like Danielle said. I'm a thoracic surgeon who mainly practices at Kaiser, Oakland. But obviously have a lot of wear a lot of hats nationally in terms of in the lung cancer scene. But I think the main thing why I love and this is not just a plug for GO2, but just in general GO2 is that it is the main, why I kind of got involved was it's the main organization for patients and their caregivers. And I think that's what you're seeing here today. For example, two family members are here from one of my patients that passed with stage 4 lung cancer. And so they came, and I think that's kind of what sells that, not sells, but that's what, sells it for me in that this is so important for the patients and the navigators and the caregivers and the family members that I think is different than a lot of the other, and again, I'm a part of other lung cancer organizations and all that's important, but it's more about like, okay, this is what you want to do, this is who you want to, this is what you want to do for this stage and this stage. And we're going to talk a little bit about that, but I think this really focuses on the whole, the family and the caregivers, which is ultimately what we end up talking to just as much as the patient. Because, right, you as the patient, right, John, you as the patient, you're taking it in, I have lung cancer, but it's like, it just kind of hits you, right? I mean, I don't have lung cancer that I know of, but I can imagine if I'm told that, whether it's stage 1 through 4, you just kind of, not necessarily shocked, but a little bit shocked, a little awe, and all of a sudden people just start talking at you. And so to me, this is a long-winded answer, but I like to really kind of focus on the family and whether it's caregivers or friends, whoever's there as well. Like I treat that just like it's almost like talking to the patient. And I know that's maybe a different vibe than some doctors will give, right? But for me, I notice that it's really important that the family understands it too, because honestly, the patients, no matter how smart you are, no matter everything, you don't remember everything. And then for this group here, this is a very highly English speaking group, but imagine if you don't speak the language and I have a translator. So in those situations, for those of you online, that's why I think it's really important that we all remember that the family, you all, the caregivers, the friends, right, the friends that are here, that you're just as important, if not more, to the patient themselves and getting the right care.
Yeah, I couldn't agree with you more. And having talked with people over the years, and I think you're absolutely right, at diagnosis, and to your point, regardless of stage, it's like you hear those words, and then it's like the old, for those who who remember, but the teacher in the Peanuts cartoons, which is that wah in the background, right? Everything kind of goes numb and quiet inside your brain, and you hear the words, but they're not as meaningful. And I couldn't agree more that the caregiver role is such an incredibly important one, not only to help navigate a diagnosis, but to help support the person in other ways through that. So thank you for that. So tonight we're going to be talking about the role of thoracic surgery with medical oncology. When Dr. Das gets here, we'll have her interject. And of course, Dr. Velotta knows all about it too, so he can answer all of these questions. But a lot has changed, in the last half a decade or so, particularly when it comes to earlier stage disease, but also in later stage disease, and some of the things that we're looking at from a surgical standpoint, and what role the medical oncologist and the thoracic surgeon play together. So before we jump into the meat of the conversation, what is your role as a surgeon?
So me as a surgeon, just what Danielle said, even the last decade, I would tell you the last year. I was here a year ago talking a little bit about kind of early stage and surgery, and then now you can see the topic already, right? Surgical options in all stages, right? So even in a year, things have changed that we're going to talk about today about other therapies other than just surgery, but in addition to doing surgery, which we didn't have. And so I think and you'll see with Dr. Das here, that it's even more important now that you have your thoracic surgeon. We'll talk to you about surgery, and we can tell you whether or not you need radiation, or whether radiation may be better, or to see a radiation doctor, right? That's also an option. Or whether or not maybe you just need some type of systemic therapy with your medical oncologist, or a combination. But more than likely nowadays, when we talk about anywhere from stage 2, stage 3-ish, and even to stage 4, it's a combination approach. You have to have your thoracic surgeon be able to understand the nuances of what medication may be the right thing to do with your surgery, because that's what we're seeing now. We didn't see that for a lot of you here that even operated on. We didn't see that because that just wasn't those options. But now these clinical trials have produced good results, and so we are seeing way more thoracic surgeons now working with medical oncologists for pretty much every stage now. Okay, the only stage that I'll just be completely transparent. The only one that I don't think everybody's totally got on board with, and even no matter where you're at, whether you're at Hopkins or Harvard or Kaiser, it doesn't matter, is the stage 1A. Okay, so that means your cancer is less than 3 centimeters essentially, and you've had treatment. That is still, but there are clinical trials looking at that to have other treatments other than just surgery, or a combination of surgery. So I think we're headed towards that. But then everything other than that, so stage 1B and on, now really should be with medical oncology. And I will tell you, that was not what I was talking about a year or two ago, that it was important. It was okay, if we operate on you, we can kind of take care of it, or your local surgeon in wherever, Santa Rosa or wherever, can take care of you. I would say no, that's not the case, because there's so many treatments even after surgery that you can get that you may not know that you qualify for, or we'll get into it, but biomarkers, right? And I know this is not a biomarker talk, but that are still not getting biomarkers. So you really do need to have your medical oncologist on board with your thoracic surgeon more than ever.
Yeah, I agree. And I think, we know that lung cancer is an incredibly complex disease, particularly all the things we know about non-small cell lung cancer, which is where we're focusing tonight. And historically speaking, to your point, the job of the thoracic surgeon was to go in and cut out the cancer, right? And now, because of studies and trials and data and the information that we have and we know, we're bringing in medical oncology earlier in a staged diagnosis. And this is why staging is so incredibly important, because the data and the studies have shown, or let me stop for a second. What we know historically, and I would love for you to speak to this, is that just because someone has surgery and the cancer has been taken out doesn't necessarily mean the cancer won't come back. I mean, the recurrence rate historically, without any sort of pre-surgical or post-surgical systemic therapy, the recurrence rates were pretty high, right?
Correct. And so we've always kind of known that the recurrence rate, this is anywhere, even for early stage, can be anywhere from 5 to 25%, right, for stage 1 within 5 years. And it's even higher if you have stage 2, 3, or 4 initially. And again, everybody's different. Everybody's different depending on, especially with personalized medicine. But generally speaking, yes. I mean, we were just talking about it earlier, right? Stage 1, went to stage 3. And that can happen. And that's okay, though. I think 10 to 20 years ago, I think we would have been, and some of you have been there that long, so you probably knew what it was like back then. Like, stage 3, oh my God, it's recurred, right? Now, we kind of know that. Like, we've always known that, but now we have things that we could do for it, right? We talked about that. The dual immunotherapy, right? This was literally just 5 or 10 minutes ago. So there's so many different things that we could do, whether it's immunotherapy, chemotherapy, or even targeted. Hey, Dr. Das, targeted therapy, which Dr. Das will go into. But there's so many other things that we can do for early stage disease to prevent that. But even if it does come back, because classically we watch early stage disease afterwards, that if it does, we are on top of it because we have biomarkers now. We know exactly what, and there's even these new tests that we can tell you what's your likelihood that you may have a higher chance of recurring or whatnot, even if you're stage 1. And so there's all these new things. And so so you need your thoracic surgeon because they operate on you. You got to know about, they have to know that we did the lobectomy, we know how you're going to feel, are you having wheezy, but you need the medical oncologist to be ready right then and there, and so you're not like, oh my gosh, recurrence or whatnot, because that does happen. We all know that. The key is you just live, right? You live like it's diabetes and high blood pressure. You just live with it. It's not necessarily like, so I try to tell patients if they do have like a little recurrence here and there or whatnot, that there's so many treatments that we can do for now, and in a combination approach. Right? It doesn't have to, it could even be surgery, it could be radiation, it could be chemotherapy, immunotherapy, targeted therapy, but there's all that. So many people like you all are living with that, and you just live with it like it's a chronic disease. So I think that's really why I think it's so important.
Thanks, Jeff. And everybody, I'd like to welcome Dr. Millie Das, medical oncologist. And before we start, will you just tell me a little bit, or tell them a little bit about yourself, and then I'll kind of catch you up on where we are.
Sure, thank you. I'm sorry for the delay. My name's Millie Das. I'm a thoracic medical oncologist, practicing both at Stanford University and at the VA in Palo Alto, and it's really a pleasure to be with you all today. And one of my passions is clinical trials and clinical research, and really engaging with patients and talking about all the different treatment options. I think this is a very exciting time to be practicing in lung cancer, given all of the advancements and all of the new drug approvals that are happening. It's seemingly on a week-to-week basis, and so it's really wonderful to be working as part of a multidisciplinary team to really offer the best treatment options for our patients.
Yeah, thank you. I think we were just getting started and talking about the roles of a thoracic surgeon, and the role of the thoracic surgeon really being, historically anyway, sort of this one-man show where you'd go in and you'd have the surgery, like I said. But now, because of the studies and because of the data and because of what we know, and Dr. Velotta was just going over recurrence rate historically, that we needed to do better even for early stage patients, and how can we treat systemically, which is the role of the medical oncologist, and work together with the thoracic surgeons to ensure the best outcomes for our patients, right? So, and I was talking about how complex this is, and we thought it was complex when we started identifying different biomarkers, right? But now it's even more complex, because even I would assume, Dr. Velotta, that your knowledge base had to expand into medical oncology to a certain extent, right?
Oh yeah, I mean 100%. That's kind of what it is now. I mean, I think you see, like you have to interact a lot more with medical oncologists, but not just the medical oncologists locally, but nationally, and at these meetings. And when we have meetings for surgical meetings or surgical side meetings, or these multidisciplinary meetings, whether it's the American Cancer Society or whatnot, that you're just intertwined together so much more, and we have so much to learn from the medical oncologists that they've always kind of known, but now they've kind of really caught up to the game even more with the earlier stage. Before, right, it was classically med-onc, stage 4, surgery, everything else, right? And that's it. That's totally changed now. I mean, right, like last year when I was talking about early stage, it was just me. Now you have Dr. Das and me. It's not just coincidence, right, that you have both of us up here talking about surgical, perioperative, or we'll get into terminology, but the multimodal treatment of all different stages. So I think, yeah, like that's why it's important. So if you have your doctor Millie travels a lot, just like I do. It's good and bad, right? Because you want us here all the time, but you also need to talk to your doctors just to stay up to date with everything, to see, hey, what are they doing in the East Coast, right? It's sad, but the meetings help you with that. And yes, I wish I could say that we could all just call each other every night and be like, hey, whatever on the East Coast, hey, whatever. You would think that we do that. Medical oncology probably does that more than surgery, but surgeons, we don't do that. It's like, that's just a surgeon thing. But when we do see each other at these meetings, it's like, oh, you do that, or oh, you do that way, or you use that. Oh, you don't take the diaphragm out. Anyway, but what I'm saying is, so that's why it's so important to have your doctors that are kind of involved with the societies and with multidisciplinary care.
Yep. So, Dr. Doss, you mentioned multidisciplinary teams. Can you explain what that means to those that might not understand, and also talk about the importance of tumor boards?
Yeah, so I think when we think about multidisciplinary teams, we're really talking about engaging a lot of the different care teams to really individualize treatment plans for patients. And so when we think about tumor boards, which is a sort of a classic form of a multidisciplinary forum, we have our medical oncologists, usually several of them, specializing in thoracic oncology. We have our thoracic surgeons. We have our pulmonologists. They're typically the ones who perform the biopsies for our patients and can determine whether a lesion can be biopsied or not when we're reviewing that at our tumor boards. We have our radiologists, who are incredibly important. And even within radiology, we have a chest radiologist and we have a nuclear medicine radiologist. So radiologists who specialize in reading certain types of scans. We have our radiation oncology colleagues who are also determining whether something might be suitable for radiation treatment. So it's really bringing all of these doctors and advanced practice practitioners together in a room, virtual now. It used to be in a physical room, but now we're all meeting virtually to discuss cases that require multidisciplinary input. And so we're hearing from every different specialty and really trying to come up with the best sequence of events for a particular patient. If you can imagine, at any given tumor board, they usually last about an hour. We're typically discussing 20 or more cases, so it's not that we can spend a whole lot of time, but we go through it. We're pretty efficient. We go through each case pretty efficiently. We work together so often now. It's usually weekly that we meet, that we can sort of anticipate what the other's going to say. But I think it's really important. You know, it's not, you wouldn't go to a medical oncologist to get a surgical opinion. You really need to hear that from a surgeon. And so we do want to make sure our surgeons are there providing input. And then if we are recommending surgery, that, you know, if that patient is my patient that I'm seeing in clinic, I'm going to refer that patient subsequently to see a surgeon. And so this is where I think it just cuts down the time for our patients too, because we make these treatment decisions and then we can sort of direct patients in the correct ways rather than having them see everybody at different times, if that makes sense.
Yeah, it does. And I think I want to jump into the diagnostics and ultimately the treatments by stage, but also historically, you know, since the discovery of biomarkers and targeted, you know, biomarkers in particular, biomarker testing was done on late stage patients. And that has been flipped on its head, right? And so there is a learning curve, and that's one of the reasons, and I'm just gonna give this plug to all of the people who have been diagnosed and their loved ones who may be watching. It's one of the reasons we are so adamant for those who want to learn about their specific diagnosis to come to, you know, educational meetings like this and to educate yourselves as much as you can, because particularly if you're in the rural setting, which 80% of the patients roughly are being seen in the community setting and in some rural areas of the country where the providers or the docs that are seeing you don't have the benefit of going off to conferences and being able to in real time get this type of information. So quite often the patients or the caregivers themselves are the people asking the questions to their providers and actually giving them the information that something, you know, might be new. I think that's the case in these earlier stages too, with biomarker testing being important there. So Dr. Doss, who should get biomarker testing and at what stage?
I mean, arguably everyone should get biomarker testing. I mean, I'm a big advocate for that. So regardless of stage, regardless of histology, but if you really want to think about the patients who absolutely should be getting it because it's going to impact their care, it's really patients with non-squamous histology that we're thinking about. Those are patients who are more likely to have driver mutations. Now, as we're thinking about some neoadjuvant treatment approaches, we're thinking, again, as Danielle mentioned, it used to be sort of later stage patients, all the non-squamous patients with stage 4 disease would get testing, but now we're testing patients with stage 2 disease. Anything beyond stage 2 disease, we should at a minimum be getting EGFR, ALK, and PD-L1 testing. But again, I would argue that we should be getting next generation full sequencing for any patient with non-squamous histology who's stage 2 and beyond. But in an ideal world, I think we should be getting this testing done reflexively. So if the pulmonologist ordered or did perform the biopsy and the result comes back as any form of lung cancer, that tissue should get sent for the testing so that those results are available to the treating doctors, because we just don't want to be behind the ball. We want to have that information so we can sort of move forward. If we're having to order the test, it only delays things. So I would say, I'm a big advocate for doing this, but as we know in the community, it's not happening routinely. And I think the other thing is making sure not just that it got sent, but that the results came back and someone's actually reading those results and interpreting them in the appropriate way.
Mm-hmm. And I think there's something very complex about this staging. What am I trying to say? So someone might be diagnosed with what we think, based on scans and upfront diagnosis, is a stage 1A or 1B, but it's not until your surgeon gets in there and can see what's actually going on. There's a potential for restaging. So some folks might actually have the biomarker testing prior to surgery, and some it might be, okay, now after surgery, we need to go back and now do the testing, because since Dr. Velotta got in there, or your thoracic surgeon, you have been upstaged or restaged.
That's why I'd argue to try to just do it on everybody, because you don't know what's going to happen. And sometimes even in these stage 1 patients, when you're hoping for cure with surgery or radiation, and if you do have a recurrence, you don't necessarily want to be doing it at that time, right? Having that data soonest is best.
Yeah. Dr. Velotta, we're going to be using a lot of, and I'm just going to bounce back and forth, but you guys feel free to chime in with one another. A lot of medical terminology today, particularly neoadjuvant, adjuvant, perioperative therapy. Can you explain what each of those terms mean?
So thanks, Danielle. So you already heard me start to say a weird term, right? I don't expect you all to know it. Even we have to tell clinicians what that means. You heard me say perioperative, right? You're like, what? What is that, right? So let's back that up. So essentially now the way you look at it for lung cancer, right? You have surgery. If we talk about surgery first, right? We'll just go from if we're talking from a thoracic surgeon. You have surgery. You can get surgery first, up front. So that's where if you hear surgery first up front, and then you get maybe, if you're a candidate for maybe getting something afterwards systemically through targeted therapy, chemotherapy, immunotherapy, that's what you hear, where you hear adjuvant therapy. Okay, so surgery first. And then if you have therapy afterwards, it's called adjuvant, like an adjunct, right? So it's surgery first, and then you get a little bit of something in your bloodstream afterwards, whether it's through a pill or through an injection. The neoadjuvant, so you do have to, I'll be honest, right? I think you do have to know some of these buzzwords, because we just use it so interchangeably now. But if you do neoadjuvant, that's kind of where I think the really new realm is that you don't go to surgery first. And you have early stage disease like stage 2. And classically, we took all those patients to surgery. But now there's a big push because of these new findings that there's some maybe better results if getting something beforehand. So chemoimmunotherapy beforehand. So neoadjuvant means you get something systemically before you come see me. And I think that's really what you have to kind of realize, that's changed. That's what's changed so much. So when you do see a surgeon, you may need to see a medical oncologist, because if your surgeon doesn't know, or if their common practice is no matter what, stage 1 through 3, we're trained prior to all these studies to just chop it out and then you go see an oncologist and then they give you something, that's not the right thing anymore. That's changed. So that really is when you do need to see somebody else. And then the hardest thing to understand, and I think Jessica Donington, who I'll call it because she's amazing, she's a chief of thoracic surgery at University of Chicago, she'll call it the sandwich approach, but that's the other term for that is perioperative. Perioperative, and these are some newer studies that have come out where, and I even have a patient, she may be online right now, she's getting it right now, and she just finished the perioperative. And perioperative just means that you get chemoimmunotherapy beforehand, then you get surgery, and then afterwards, you also get some immunotherapy afterwards, and usually they try to do that for a year. But again, that's the sandwich approach. So now you're getting it before and after, right? And so versus, oh my gosh, it's already crazy because you're getting it before and then surgery. So I think that's kind of what those three terminology I think you have to know. And so perioperative is kind of the most complex one for most of us to understand. So if you think of sandwich approach, where you get it before and after, like just the double whammy, and this is where we can maybe, if we get complex into it, like the differences of that, because there's so many different unique, that's why you need a tumor board. You may get 5 different opinions about which protocol to do and whether you should even do it afterwards. But I think that's the nuance here, is that sandwich approach. If you guys can start to remember that's out there right now, that and whether or not you or your family are candidates for that.
I've never heard it called the sandwich approach before, but it makes perfect sense. Like I can see it, you know.
I can't take credit. I gave Dr. Donington, who could be listening. I don't know. Yeah,
but I think, and we're going to jump in now to sort of by stage and what this sort of looks like and what has changed. And Dr. Stoss and Velotta are going to talk about some of the data. Before we do that, I want to thank all the people diagnosed who have made the decision to join in these trials, because without you, we would not be where we are today, with the advancements that we know are having great impact on the lives of those who have been diagnosed after you. So a huge thank you to all those who participate. And you know, I want to point out what we just said, and please feel free to ask questions. I was remiss in saying that at the beginning, but this meeting is for you. That goes for our online audience too. Our very own Michelle Zay is in the back, ready to take your questions and ask on your behalf. But this is complicated. It's complicated stuff. So we want to make sure that you leave here with a deep understanding, or a great understanding. Maybe not deep. If you need to go deeper, you can always call us afterwards. But it's complicated. And Dr. Velotta talked a little bit about historically and the recurrence rate, and what we have seen in this data by either the neoadjuvant, the adjuvant, or the perioperative systemic treatment is great improvements. Mm-hmm. So, Dr. Velotta, I'm going to ask you to start with 1A, because that's typically you.
Yes. So 1A, the way we think of 1A is if you have one lung spot, and it's usually less than 3 centimeters. So, right, which is about an inch. An inch is like 2.5 centimeters. So if it's defined that small and it has not spread to lymph nodes or anywhere else, that's classically kind of like your 1A patient. So usually the standard of care would be, or the standard of care I would just say is surgery and or SBRT, which is kind of like a localized radiation. So again, that's not the talk that we're going to talk about today necessarily, but just know that there is an option that you have if you don't want surgery, or if you're, or if you don't, have a lot of medical problems, and and you're not able to walk or whatnot. So yes, there are, but classically it's local therapy. So you either zap the heck out of it, nuke it, right, or you chop it out, right? That's classically stage 1A. There is currently no FDA approved or anything that we give before for those small little tumors. And so the idea is you treat it first, chopping it out, or you zap it, so with surgery and or radiation. And then this is where it gets a little complex. I don't want to get too into it, but generally speaking, we don't recommend or give things, and I'll let Dr. Das go into it, but we don't give things afterwards. However, I will say that's why I'm also like Dr. Dawson. We are two different doctors, two different systems, but I am a very big believer of reflexive testing for all stages, because guess what? There is a clinical trial going on, and it is going on, and it's called ADURA 2. And this is, again, I'm no stake in the game, but this is looking at if you're stage 1A. taking a pill therapy if you have a targetable mutation called EGFR and doing that. And I don't know what that's going to show, and I'm not a representative for them, but just know that that's where things are headed. And there's even newer ones where they may start giving it before earlier. And so if you look at other cancers, that's kind of what they've done. Is either earlier the disease, like if you guys know breast cancer, the earlier before it was like breast cancer, chop out. Now it's like give chemo for everything. Mm-hmm. I mean, I don't know. I'm not about breast cancer, but I'm surprised that everyone's like stage 1 giving, so I guess what I'm getting at is that stage 1, yes, I don't want to complicate it, you chop it out. But I do think, and I do this for my patients, and I wish we could say we could do it for everybody, no matter where you're at. But I do get biomarker testing now for that. That's a newer thing, but because you could qualify for, like we said, a clinical trial, and whether or not you need it, that's a whole discussion. And that's where you now need also, besides you don't want just me telling you about osimertinib and everything, you want to hear it from Dr. Das about osimertinib and about the rash and about diarrhea and stuff. You don't want to just assume that I know it all, right? And so that's where we're even getting medical oncology involved even earlier. And I'd say I'm a little getting ahead of ourselves, but that's ultimately where I think the future is. So you're going to even see us combine at the hip even more so. But again, I didn't want to complicate it, but I do want you to just know that, hey, look, even now we're ahead of the game and we're starting to look at the early stage.
Yeah, and there are clinical trials being done even at the 1A stage because we've seen so much improvement in some of the later stage. Mm-hmm. You mentioned reflex testing, and just so everybody knows, that's going back to what Dr. Das said earlier, like, let's not wait and see, let's just do it, right? Let's just do the testing once a cancer has been identified, regardless of stage. So now I want to jump into the adjuvant space, which we've had meetings here in the living room specific to adjuvant therapy in earlier stage lung cancers, specifically stages 2 to 3C. Can we talk a little bit about what we learned and what's going on in that space?
Yeah, I mean, I think historically we've always talked about chemotherapy, adjuvant. So, so after patients with stage 2 or 3 lung cancer have surgery, they're referred to see a medical oncologist to talk about additional treatment after surgery. And we have a number of different options, and part of it does depend on the results of the genetic testing that's been performed on the tumor tissue and on the PD-L1 results. So we have cytotoxic chemotherapy. It's usually platinum-based chemotherapy that we offer our patients with stage 2 and 3 lung cancer after surgery. And then after the 4 cycles of chemotherapy, we have the options of immunotherapy and targeted therapies. And again, those options are going to depend on the PD-L1 status and whether a patient has EGFR or ALK. And because we do now have FDA approvals for osimertinib for our patients with EGFR mutations based on the ADAURA study, and for alectinib for our patients with ALK translocations, and that's based upon the results of the ALINA study. So both of these studies involved patients with stage 2 and 3 disease who've had surgery and then go on to get the targeted therapy. Typically, we're still thinking about chemotherapy for our patients and then thinking about the targeted therapy after that. For patients who don't have EGFR or ALK, we have FDA approvals for immunotherapy after chemotherapy, and that's usually given for a year after the 4 cycles of chemotherapy. And we know that the patients who have high PD-L1 expression, which is defined as greater than or equal to 50%, those are the patients most likely to benefit from that immunotherapy given adjuvantly. Though again, this is a discussion that we have. We always have to talk about risk benefits of all these different treatments and think about what that's going to involve for the patient. But these are the conversations. So after surgery, we hope to see our patients back to talk about chemotherapy, to talk about the potential for targeted therapies and immunotherapy.
Yeah. Can you talk a little bit about what some of that data showed in the trials insofar as recurrence rate?
Yeah. So particularly for our EGFR and ALK patients, we saw really a dramatic reduction in terms of recurrence, and also not just systemic recurrence, also recurrence in the brain, because we know that that can be a particularly devastating site of disease recurrence. And so both osimertinib and alectinib can get into the brain to prevent metastases from occurring in the brain. And so we saw pretty, I think, pronounced benefits with these targeted therapies and in the clinical trials, both ADAURA and ALINA, and these were data that were presented at major conferences, and people were very excited to hear the results. ADAURA in particular, we heard the data presented at multiple ASCO meetings and in the plenary session, really to standing ovation from the medical oncology community because of the sort of the excitement about the benefit that we're seeing for osimertinib in these patients who've undergone resection. And so this is now really standard practice. And in ADAURA, the osimertinib was given for 3 years, and that's really what the FDA approval is for that 3 years. The 3 years is somewhat arbitrary, though, and so many of us now, when we have these patients that we're seeing in clinic who've been on the drug for 3 years, we're having the discussions about, do you want to continue? Because we know that when you discontinue the drug, the chance of recurrence then goes up a little bit. And so, I think at some point in the future, my hope is we'll get to be able to track tumors through circulating tumor DNA, where we could do a blood test and then decide how long we should be continuing a therapy. For now, we're just sort of stuck with the way the trials were designed and the duration of treatment that was chosen for those studies. So in ADAURA, it's 3 years, but I do have some patients who say, I'm doing well on this drug. I don't really want to stop it, and we're able to get the insurance to authorize continuation, and so patients will continue for year 4, year 5. We also have approval for osimertinib in our locally advanced patients. I know we're not talking a whole lot about that, but patients who are getting chemoradiation for stage 3 disease, this was the LAURA trial that was presented at ASCO last year in the plenary session. Again, these are patients with EGFR who've gotten chemoradiation, and then they get osimertinib indefinitely after chemoradiation. Huge benefit compared to just observation. And so this is now also part of standard of care. So these targeted therapies we know can, have a big impact in terms of preventing recurrence and also delaying recurrence in the brain. And so this is what's exciting about these drugs.
It's really exciting. So just to make sure that everybody understands, you're both involved in the treatment planning up front for this subset of patients. They come to you, they have this surgery, they recover beautifully. Mm-hmm. How long until they start a systemic treatment plan?
We usually want our patients to be fully recovered from surgery, and so typically the earliest is around a month after they start, and but I think more typically between that 4 to 6 week window.
Okay.
Yeah.
That makes sense. Does anybody have any questions before I jump into adjuvant? Michelle, are we good online? Pat, do you have a question? I saw you kind of question your question.
Could you repeat what Asumar or whatever?
Osimertinib, yeah.
Yeah, thank you.
So that's also known as Tagrisso. So osimertinib is the 3rd generation EGFR targeted drug that we're using, yeah.
Thank you.
Yep.
Anybody else? Oh, Betty, we need to get Betty a mic. I'm just taped to the chair, so I can't do that. Okay.
Hi, I'm just wondering, does the Tagrisso go through the blood-brain barrier?
Yeah.
Then that's how it's able to protect long-term.
Yeah. Yep.
Thank you.
Yeah.
Yeah. Thanks, Betty.
Hey, everyone. I just had a question. So what is the typical disease pathway for EGFR, just in terms of how it evolves in the body, and then what are the kind of key milestones that are likely to happen as it evolves?
Yeah, that's a good question. It's tricky. It's not the same for everybody. So if we are lucky enough to pick up the lung cancer at an early stage for EGFR, then again, typically our patients do quite well because they can get the surgery, and then we typically give chemotherapy, and then we give the osimertinib or the Tagrisso as adjuvant treatment, and then we have many patients who are cured with that approach. There are a subgroup of patients who will recur, and when that recurrence happens, it can really occur, it can happen anywhere. But the brain is a common place where we see recurrences. We can see recurrences really anywhere else, though. But particularly patients with these driver mutations, we know that there's a higher proclivity for brain. So for EGFR, for ALK, we do worry about the brain. And so I'll also mention that at the same time that we're doing surveillance scans to make sure that the cancer hasn't returned in the body, we're also looking in the brain separately. And there's not a whole lot of data for this, but we're, especially at a place like Stanford where we see a lot of patients with EGFR, we've now sort of developed protocols to make sure that we are getting brain MRIs to look for brain metastases in our patients with early stage disease that we're doing surveillance in.
Okay, thank you.
Yeah.
Anybody else? Yeah? Oh, we got two.
I think it's okay. Can you hear me?
It's for the people online.
Okay, I'm sorry. Oh, okay. Yeah, thank you. I have two friends, okay, both of them, okay, one male, one female. They were diagnosed with like a stage 4 lung cancer all of a sudden. So 3 years later, the male, he passed away, okay, and the female was still doing very well. And for the male, okay, I think they both went through the targeted therapy, and I think they have the EGFR, okay, the marker. And I heard about the drug resistance. So could you explain a little bit more, and then how it differs from patient to patient?
Yeah, I think that's a great question that you bring up, and it sort of ties in with the other question as well. So what is the sort of typical course? I mean, so it's really hard to say that, if you have an EGFR mutation, this is how it's going to go. We know that these targeted drugs, though they're very exciting, we see high response rates. Patients can be on them for a long time. We know that the common thing is that people will develop resistance. The median time to development of resistance for osimertinib, it's around 18 months. And so that's about 1.5 years. That's a median. So I have some patients who are on osimertinib for years, 3, 4, 5 years, and still not having developed resistance. I have other patients who didn't make it to that 1.5 years of not developing resistance. They got resistance either within a 6-month period, or maybe they were one of the really unlucky ones who just didn't have a response to the osimertinib at all. And so we always have to keep that in mind when we're talking to our patients with EGFR about all of the different possibilities, but you're an individual person. And so I think it's really hard to have these, as you mentioned, that's a perfect example. You have 2 patients with EGFR with very different sort of trajectories. And I think that's what is possible. And, and it's really hard. And I think it's overwhelming to think about all the different possibilities. We try to simplify it. And I do talk about medians, but again, I also remind my patients that these are just statistics, and you're an individual. Hope is that this drug will work for you for much longer, but we will keep a close eye on things. We'll make sure that we know when it stops working, and we have other drugs that are effective even when the targeted drug stops working.
Question. So I'm kind of new to this lung cancer field, but I'm curious about this. So in terms of biomarker, so I understand, yes, after surgery, you are going to test that. But before that, is any kind of symptoms shows that this is more EFGR kind of prone the problem or not? That's one thing. That's one question. The second question is, so for example, if this is not really the problem, what else things can help? Because this one may have medication already, right? But other things may have different genes may cause the problem. So any kind of solutions to this lung cancer recurrence?
So I think that's a good question, because we're really focused a lot on EGFR, but there are so many other driver mutations. And so that's why we do need to do the broad sequencing. And so when we talk about the molecular testing, again, we're advocating to try to test everybody, regardless of the type of lung cancer. We do know that these driver mutations tend to occur more frequently in people who have never smoked and in people with non-squamous histology. But I have certainly seen driver mutations in patients who have smoked. I've also seen driver mutations in patients with squamous histology. And so that's what really pushes me to want to really test everybody. But at a minimum, I would say for the patients who have never smoked, those patients we typically think have a more than 50% chance of harboring a driver genetic mutation, whether it's EGFR or some other alteration. And you asked about targeted therapies for other mutations. Yes, so this is what's exciting in our field is every few weeks we're getting new drugs that are approved for other targets. So we're talking about the classical EGFR mutations, the exon 19 deletion and the L858R mutations. That's where the osimertinib or Tagrisso is quite effective. We also have exon 20 insertion mutations in EGFR. The patients with that particular mutation don't tend to respond well to osimertinib. But just as of a week or two ago, we have a new FDA-approved oral targeted drug for patients with that particular mutation in EGFR. And so again, we're seeing a lot of new, exciting targeted drugs for a lot of these other mutations that are frequent in a lower percentage of patients. But again, it doesn't matter if it's 1% or 2% of the non-small cell lung cancer population. If that's you want to have access to that targeted drug. And so that's why we should be testing everybody, and we should be making sure that we're identifying these driver alterations on the results when they come back to us, and we think about the different targeted drugs that are approved. So we have now many different, so I talked about EGFR, ALK. We have other alterations such as RET, NRG1 fusion, which is a very rare fusion that we see, but sometimes when we see it in non-small cell lung cancer, we now have FDA approvals. We have HER2. The list goes on and on, BRAF. So I think that's really the goal, is to try to identify that target in each and every patient specimen so that we can come up with a targeted drug that's going to benefit the patient.
Yeah, and I think when we're talking about surgery and adjuvant therapy or post-surgical therapy, we tend to kind of lean in on EGFR because it was the first one, right? Similar to when we're talking about targeted therapies, we kind of lean in and start there. But I could not agree more that this comprehensive approach to the biomarker testing is so incredibly important. Because if all we did was test one at a time, imagine how long it would take, right? And I think this type of systemic therapy before, after, or sandwiched in between started with EGFR, but it's already branching out, right? And so just because you're an NTRK or a BRAF or a HER2 patient, or your cancer is HER2 or NTRK or BRAF, doesn't mean that something won't come in a clinical trial that proves to be effective for you too.
There
right?
are ongoing clinical trials with a lot of these other rarer driver mutations in the early stage setting. These drugs get approved first in advanced stage, and then they move into the early stage. And so we have the data now for EGFR and ALK, but there's a lot coming.
So when we're talking about neoadjuvant or before surgery, is it similar to the post-surgical or adjuvant type of therapy, and sort of chicken or egg, sort of, which comes first, and like who's having these conversations? Are you guys having them together? Are you, whether you're at Stanford or at the VA or whether you're at Kaiser, is the medical oncologist and the thoracic surgeon in the room at the same time having these conversations?
I mean, Jeff, I don't know. Typically not at the same time. I think part of it depends on the referral pattern and if the patient's been referred to the surgeon, and then that's when the surgeon will introduce the idea of neoadjuvant and then make sure that the patient gets referred to a med-onc.
Yeah. So just to, exactly. It's ideally, the ideal situation is you come in, right? And it's Dr. Doss and I, and like you have stage 2, right? Or whatnot, and in person, right? But that's never going to happen for now, so the reason why this is important, I think this is, now we're getting into the meat of it, like what I'm hoping that kind of the novelty of it is stage 2 and 3, okay? So generally speaking, for example, our tumor board that we run, and we run it once a week for our thoracic tumor board, ideally, in the ideal situation, no matter how many cases there are, now with the neoadjuvant, perioperative, adjuvant approach, all stage 2 and 3 should be discussed in a tumor board setting. Doesn't matter if you're 95 or if you're 25, all of that should be, because are you gonna do surgery first? Are you gonna do chemoimmuno first? What's your biomarker? Did you just get EGFR and ALK? Right, or did you get the full panel? I don't want to complicate, but bottom line is that is important. So if you do, quote unquote, have, and it's usually clinical staging. What do we mean by clinical staging? That's complicated too. That just means based on basically your imaging. You get a CT scan, a PET scan, and the doctor tells you, I think you're stage 2. And maybe we did some lymph node biopsies and maybe not, right? And everybody does it differently. So if you hear those buzzwords, not stage 1 for sure, or whatnot, and it could be stage 2, it could be stage 3, you need to be presented in a tumor board. Because that's where, even though Dr. Doss or me, that wasn't in on your case, we'll be in the tumor board. And we may look, and we can tell a lot. So surgeons can tell a lot by imaging, right? And the doctor, whether it's primary care doctor, oncologist, whatever that may, or pulmonologist, right? They'll be there too. Oh, that patient looks pretty good. So then it's all about imaging and what the next steps are. So just if you're presented in tumor board, you're already, that's good, right? And then because that tumor board will then recommend maybe we think about doing chemo immuno first, or maybe we think about just doing surgery first. And those nuances, that's where we're at right now. That is so complex. That will change week by week, surgeon by surgeon, medical oncologist by medical oncologist, for stage 2 especially. That is the most heated debate right now, right? If we were going to be simplified, let's simplify it real quick, even though it's not simplified. Stage 1, you usually chop it out first, even stage 1B. Even though maybe you could give something beforehand, really it's just chopping it out first, and then we'll see what you do afterwards in terms of what your biomarkers are and everything like that. Stage 2, that's 50-50.
Yeah.
The clinical trials do show some benefit a little bit in the stage 2 patients when you break it down, but it's really the stage 3 patients. So stage 2, it's like maybe either way, you're gonna have surgery involved. You're either gonna do it before or after chemo or sandwich approach, right, for stage 2. Then stage 3, right? So the thing that that I would focus on if I was like a patient listening to this, and again, this is all our opinions, everybody's slightly different depending on who you talk to, but stage 3 is where it's really changed, where I think that absolutely you need to make sure you have a medical oncologist, a radiation oncologist, and a thoracic surgeon involved, where I will tell you in the community a lot, they are still chopping it right out in the front, or what I think is even worse is that they're just going straight to the Pacific trial, which is chemorads and a year of immunotherapy, because that's what came out in 2018. That is the gold standard, even in the NCCN guidelines. That's really what most people will do for stage 3 disease, not even offer surgery. And we still deal with that now, and this is in the Bay Area. So I think with stage 3, there's so many different options, but stage 3, I would say it's less common now if you have stage 3 disease to just chop it out. Or just get chemoradiation and not do surgery, okay? That's where you need to have surgery involved, but most likely the big shift and where all these new clinical trials came out was that in stage 3 disease, giving some chemo immunotherapy, assuming, again, that you're not EGFR or ALK, that's a whole different subset we're talking about, but that's a lot of other patients, right, that are not EGFR and ALK, that you should consider getting some type, if you're going to be surgical, to get some type of chemo immuno beforehand and not just to take you straight to surgery. I think that's, the clinical trials show the biggest benefit in that. And I will tell you, even in the Bay Area, that's not necessarily happening still. And so I think that's where we still need some work to do. We can get into the weeds with stage 2, but that could change based on each day that you talk to us and everything. So the stage 3As, I think that's where you really have to get on board with, you know, before it was chop it out first and then give something, or just chemoradiation, no surgery. That needs to change. That should be, you should be getting most, you know, I don't want to go on a limb because I don't know everybody's cases, but that we need to do a better job in our tumor. We're really trying to do a better job to say, what about chemoimmunotherapy, then doing surgery? And that's what a lot of these clinical trials are showing. But yet, I will still tell you, it's hard to convince people to do surgery for even stage 3 disease, for even stage 3. I mean, I would love to talk about stage 4 in a little bit, but that may be too crazy for today.
And I think stage 3...
I know, we're going to.
Well, stage 3 comes in so many different flavors too, right? And I think that one of the biggest questions that we always have for our surgeons is this resectable or not? And I think the definition, I'd love to hear from you, Jeff, I mean, the definition of resectability has definitely evolved as well, right? And so if we deem a patient resectable, that's when we really start thinking about the neoadjuvant or the perioperative approaches.
Correct.
If a surgeon really feels it's too risky to perform surgery, usually because of bulky lymph nodes or because there's just multiple levels of lymph nodes, then that's when we just completely change our treatment recommendation to chemoradiation and we involve our radiation oncology colleagues. But you know, what I've noticed is just that definition of resectability has really evolved over time. And I think as we think about some of these neoadjuvant approaches, I think we're even pushing the envelope a little bit in thinking about trying to make traditionally unresectable cancers potentially resectable. And I think then that's where our field is moving. I'm not suggesting that we need, you know, we should be doing this, but you know, it's just something because we're seeing such good efficacy of these neoadjuvant treatment approaches where we're seeing significant shrinkage of the tumor. So can we push that envelope and maybe think about taking out tumors that we wouldn't have traditionally thought about? But these are the things that we're doing.
And I think it is exciting and important to be talking about now. And by resectable, just so everybody knows, that means can it be cut out? I mean, that's what we mean. Can a surgeon go in and actually, you know, get everything out? And that has really evolved. And thoracic surgery, I remember when my own mom was diagnosed in 2003, she had a thoracotomy, so she's got that big old wraparound, scar, and sometimes that still needs to be done. I mean, it depends on the complexity of the surgery, but the advancements in technology and surgery and the way we're even doing that now have come so far.
Yeah, to go with Dr. Das is saying, I mean, that's the issue. That's why I think it's so important that whether you get a second opinion or you get a tumor or the other thing, because what us as surgeons think is resectable, and so there's two things. Operable is how you all look here. John, you look pretty good. Okay, you're operable, meaning you're going to tolerate. I think you're going to tolerate an operation. Okay, and then resectable is just me looking at the imaging. What it's going to like, looking at the CT essentially. Is it invading the heart? Is it, are there lymph nodes like crazy everywhere? And so that's resectable. I will tell you, so operable, right? Most surgeons can usually agree if you put us all in a room and we see you, or it could be on video. It could be on video. We could tell on video. I know people don't want to believe that, but we could tell on video. We could pretty much all kind of agree. Okay, she or he is operable. They'll tolerate an operation. Okay. So that's one thing that you have to be, right? But what we're really getting at, the nuance, what Dr. Das and I are getting at is that the resectability. I will tell you, I'm in all these tumor boards, and I'll tell you, you could probably imagine where I am on the extreme of whether or not you're resectable or not. You're probably resectable, but I'm just kidding. But so you have all these extremes, but everybody is so different.
Yeah.
And I will tell you, you poll everybody looking at the same image, you'll get 8 different answers. And whether you're at Stanford, at Kaiser, at Harvard, at wherever. So how can you as a patient, how is that fair to you? You don't know that, right? You guys don't know that. You just go with whatever. Or you go, oh, I'm going to go to that guy or gal because I've heard they're good. They may have a totally different opinion. Yeah. And that's the nuances. And then that's already just looking at it, just the imaging, right? And now you add in that we know that there's a 80% chance that you'll get some shrinkage with chemoimmunotherapy, and the what ifs, like, oh, what if it kind of shrinks down? Imagine how much variability and how much subjectivity and how much it's based on experience and who you are and your personality, like all of that. It's not to freak you guys all out. It's to say that Danielle and I talk about this maybe too much. Second opinions, I don't care if you go to second. That's great. I'm not offended. So many patients still think I'm going to be offended if you talk to, right? Like, I'm okay with that. You guys, a lot of my patients are here. That's great because you may get different opinions. And in fact, I don't even say you may. The scary thing is you will. You will, and if we really want to get into it, let's get into it about surgery. What type of surgery? Do you have a lobe? Do you just cut out a little piece like a wedge? Do you cut out a segment? Is one better than the other? Well, guess what? There's new trials to show that there's nuances with that too. So now it's too much to say. It's not enough to say, oh, you're going to surgery. Now it's what type of surgery did you have? Did you have the robot? Did you have minimally invasive, like with VATS, video assisted? Did you have it open? Everybody will totally, and then you add in chemoimmunotherapy, which causes a little scarring, you'll get 5 different answers. So it's not I'm hoping that this will open everybody's eyes up to that. Yes, you do need to get multiple opinions. It is not dogma. It doesn't matter if you're at Stanford, Kaiser, Timbuktu. You will get different opinions and different experience levels. And it's not to say one's better than the other, but to know that it's so complicated out there with all this new treatment that's shrinking things down like mad, and you're getting these complete responses. We take it out, and now there's no tumor left, right? There's a 25% chance you're gonna have no tumor left. There's a 50 to 60% chance that afterwards you have it's called a major pathologic response, where there's hardly any tumor left in there, right? And so all of this is exciting for surgeons, it's exciting for medical oncologists, but it just causes us to totally be variable on what we recommend. And that's what I noticed. That's why the meetings have gotten exciting again, because it's now like everybody's like, it's like the wild, wild west. So you may say that that's not good, but in a way it's opened up more doors. But you as the patient have to be a little bit more educated. And maybe if you're in shock about lung cancer, that's why you need your friend here, your caregiver here, your daughter here, your son here, because there's so much out there that they need to be a part of to know what's going on, that I think there's just so much information that's what I talk about with the caregiver part.
Yeah, and you can always also obviously reach out to GO2 and others who have support and navigation services available, where they help you to come up with a list of questions to bring back to your healthcare provider to talk with them about. One of the things I want to ask you guys, and I think it's happening less now, but I don't know that for sure. I think it's important that people understand the difference in surgeons too. There's cardiothoracic surgeons, there's strictly thoracic surgeons, and then there's general surgeons, and all of them can do this surgery.
I like how you said it.
But in my very humble opinion, and were it me, and I'm not speaking for anyone but me, I would want to ensure that I was speaking to a thoracic surgeon where this is all they do. They aren't also, you know, doing open heart surgery, and they aren't also taking out someone's, you know, appendix. Like I think it's important. And there was a time when there were very few thoracic surgeon, like people specializing just in this type of lung surgery, and there's more now.
Yeah, I was laughing because the way you said it is right, because you're experienced, you've been doing this for 19 years, so you know how to guide everybody, but it is so different. Like all the stuff that I'm telling you, like it is so different. So you need somebody that really focuses on this. So classically, what Danielle's saying is true, that there's been a mix. There used to be a mix, like general surgery did a little bit, which they do everything. They operate on your appendix and your lung. And then there's the kind of like me, like just doing thoracic surgery, thoracic oncology, like lung cancer surgery. And then there's the cardiothoracic surgeon, which I'm still a cardiothoracic surgeon, but you don't want me operating on your heart right now, right? And I would. You said you have a heart. I could do it, but you don't. That's not what I do. And I'll send you to a cardiothoracic surgeon that does just the heart. Now, there are cardiothoracic surgeons out there, and in California, and not just in rural settings, I will tell you, and this is not bad per se, but they do both. So one day they'll do your open heart, not chop you, but open you up, and then the next day chop out a lung, right? And that still goes on, okay? So that is what I think the nuance that we have to know. Nowadays as much, you don't see as much the general surgeons doing that as much, even though you still may. I think what you have to know as a patient now is what's the difference between a thoracic surgeon that just does thoracic surgery, that they live and breathe, whatever we're talking about right now, all the nuances, and we just look at lung or we just look at the chest and we don't do bypass surgery and whatnot, versus the cardiothoracic surgeon that does an open heart surgery but also does a little bit of lung. I think that I'm biased, right? I think not because the cardiothoracic surgeon can't operate, they can do just what I do, all right? It's not that they can't operate. They're technically gifted. They're all that, if not more so. The issue is what I find, and this is why the tumor boards are important. I'm on tumor boards in Hawaii and Washington, other places, because they have cardiothoracic surgeons that'll be like, just tell me if I need to chop it out. Mm-hmm. Just tell me if they need a lobe or what they need to do. First, second, or third. They want it, but they want to know. Should I be operating? Should we give chemoradiation? Should we give chemoimmunotherapy afterwards? How should we stage that patient? The oncology part, right? So that's why it's not that they can't do the operation. It's like, just make sure if you do have one of those, wherever you are or whatnot, that they've done the appropriate oncologic workup, the staging workup, and then also discuss with you if you have the nuance of stage 2 and 3, or if you have 1B and you have EGFR, should you give osimertinib for 1B disease, things like that. So all these crazy things, like they don't have that expertise because you can't. Trust me, I've operated on the heart before. If you operate on the heart, you got to be operating on the heart all day, and you're just living and breathing the heart, right? And so they can dabble in the lung, which they do. I'm not saying it's wrong per se. It's just they need some guidance. And if you have somebody that's giving them guidance, it's not the end of the world. I don't want you to say all cardiothoracic surgeons are bad, because I have plenty of and she's not, but a lot of my colleagues are still doing that at the meetings. It's surprising. It's like, he's like, yeah, I did a lobe yesterday and then I did open heart. But I respect the guy. And I'm like, but I do wonder, right? Does he know everything, or he or she know about all the stuff that we're talking about the new exon 20 mutation that came out? Mm-hmm. And are you going to refer that patient, or should you refer that patient to medical oncology? That is so complex, and we're studying this day and night. So that's just something that we need to think about.
I think it's incredibly important. Yeah.
Can you comment on stage 4 in regards to what you...
Yes, we're going to jump to stage 4 now, but before you do that, I have one question. It should be there are no simple answers, I guess. Does all of this sort of start over, what we just talked about, stage 1 through 3C, with a recurrence and or a second primary?
Yes and no. I mean, I think it depends on when we think about a recurrence. And I think, Jeff, you were talking about this earlier, like if you have a recurrence, we can sometimes treat that with surgery again or with radiation. It doesn't automatically mean you have to get systemic therapy. So I think where you see the recurrence, how much there's recurrence, those all factor in. For a second primary, yes, I think those are tumors that we really just kind of start from scratch. And we know anyone who's had a lung cancer diagnosis, and even if they've been cured, and we have many of these in our clinic now, we know that they're at a higher risk of getting a second lung cancer, and we've seen that over time as well. So that's why screening is super important. We haven't talked a lot about screening yet, but screening, low-dose CT screening for eligible patients is really critical, and I think as a society we haven't been doing a very good job, and that's something that we should be doing and focusing on. And certainly anyone who's survived lung cancer, we should be screening for another second primary.
Yeah. I think that's important because I don't think that's something that people talk about enough, the screening in people who have already survived and or been cured from a lung cancer.
Yeah.
We certainly know we're not doing enough in for those who have yet to be diagnosed. But I think it's even less in those people who are, for all intents and purposes, cured, and they just go on and live their lives. And we're going to run through the qualifying criteria, and the screening guidelines at the end of this. And I know we're running late, but I do want to get to the stage 4 because it is a question that comes up a lot. And I think there's movement here, and I think in a positive way. I know I just referred a patient in the UK to Jeff to at least have a conversation because things are also very different in other countries. But do you want to talk a little bit about stage 4?
Yeah, you brought it up. That's great. We were, we did it on purpose because we don't want to dabble in it forever. Like that shouldn't be the main focus. But I think the short answer or the simplified answer for you is that is still controversial. But yes, it's like kind of like when people start talking about politics. It's like, ooh, stage 4, right? It's that buzzword. But it shouldn't be, okay? It shouldn't be, and that's why you need to go to these big centers that they have, whether it's a cancer big center or a Stanford or wherever, that people are thinking about kind of like innovative out-of-the-box thinking because there are trials ongoing right now for stage 4, surgery in stage 4. There are trials and studies already been done in Asia that are where we do see a lot of stage 4 and a lot of EGFR targeted for results with surgery. And then there's also us surgeons that have a lot of real world data. So what does that mean? Well, my patient, I just operated on her. She had stage 4. And yeah, there wasn't a clinical trial yet, but she's young or he's young or whatnot, and they're doing well. And then you start adding that up. And so it is a personalized, Millie brought it up perfectly. It is a personalized approach. The key is that not every stage 4 is inoperable, metastatic, brain, bone, everything. Stage 4 is so different. If you look at the new staging guidelines are so, like, now I can't even remember all, it's M1A, M1B, M1C, blah, 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 1 organ, 2 organs, 3 organs, how many sites? Like, because there's a different prognosis based off of those things. So even if you're stage 4, that is changed. That is not like, okay, you're just a chemo patient. Don't see anybody else. The key is, it's not that I'm saying that every stage 4 patient needs surgery, but there's certainly patients that can qualify for surgery, and there's certain patients that are probably online that I've operated on and that can be here and that are still here because of surgery. Yet, do we have to wait for the clinical trials? The clinical trials are going to be there. They're doing it right now. But I will tell you, the places that are doing the clinical trials, which they've been revolutionary at MD Anderson and others, we have anecdotal evidence that rather than wait 5 or 6 years, some of us are saying we see evidence for it, for doing it, and we do offer that now. So all I'm saying is if you're in that situation, I do think nowadays you can reach out. There are people that won't just shun you and say, stage 4 surgeon, you need to see Dr. Das. They say, no, you need to see Dr. Velotta and Dr. Das, right? And that's part of it. As long as you see the medical oncologist, the radiation oncologist, and the thoracic surgeon in a multidisciplinary thing, I think that is where the future is for stage 4. I think that is very viable. And so I don't know what answer that was. That was not simplistic. That was, it's just to know that there's hope up there. Yeah. And that I don't think, there's just too many people out there that are just like, surgery, no, I don't want to deal with that. That's crazy. That's crazy talk. But why? Who do they to say that? And what do they say that? That's just their dogma. That's just their opinion.
Well, and I think that's where the second opinions with doctors who have the benefit of specializing, right? Not everyone has that benefit, and not all medical oncologists only work in lung cancer. You know, general oncologists have to treat what walks in the door, right? And it's complicated, and it's the blessing and the curse, right? For those who can specialize, it's great because they get to go to the conferences, read the literature, learn everything there is to know about a disease, right? And I think that's where and why I continue, and this organization and others continue to push for second opinions, particularly if you're in a rural setting. And quite often, these opinions can happen virtually. You know, if you've had all of your diagnostics and your scans and everything's ready to go, that can be sent over to an expert who has the benefit of specializing, and then they can work with your doctors locally, right, to set up these treatment plans that are best suited for you. So it's so important in this era of precision and oncology and personalized medicine, where Dr. Doss, you said it at the beginning, you are each individuals. You can talk about median, you can talk about below, and you can talk about above, but nobody knows where anybody's falling on that chart. So it's so incredibly important. We're late, and that's okay because I think it's been a great conversation. But do you have a question? Yeah, sorry. Now I see your mic.
I think I will ask a very rudimentary question since you talk about the complications. So even if we go to second opinion, I mean, they have different solutions or different opinions. How can we, as a patient, judge which one we choose? We are not expert at all. Even expert has different opinions.
Well, Eugene, why don't you tell her how many? Yeah, tell her you've seen what, 3? You've had 3 opinions, or 2 or 3? 2? Oh, sorry, I didn't mean to call you out. No, but like, yeah, so you know, like you've been, like that's the thing. See, that's why your husband knows, right? She remembers like this. So yeah, that's the issue. I think that's the hardest part. That's why you need as much information as possible. Most people in your corner. You need your husband right there that has to kind of weigh in. You're going to be looking online. You're going to be resourceful. Not everybody can be, so it's really tough. I can't speak for everybody, but I think it's the more information you know, the better. And you're right. That's essentially like the devil or the curse. Like you said, like if you're getting a second opinion, it's almost like you got to maybe expect that it could be different. They're not all the same. In my opinion, it's 50-50. It's going to be the same versus it's not, because if you're already trying to get a second opinion, it's probably meaning that it's a little bit more complex than just this little dot and like it's either surgery or radiation, right? Or whatnot. So I guess what I'm getting at is that that's where you have to go. My suggestion is that you go with who you feel you're comfortable with. You have to ask the hard questions. You have to say, well, like I'll tell patients, right? So for example, like for stage 4, right? Everybody's really like for stage 4, for example, like this is, right. When you go in, every surgeon has kind of their own intraoperative decision making, which is why it's hard. You have to, to decide which is, right. And you can't just go off of name or recognition, all that stuff. This is where you as the patient can ask the surgeon, what if that? What would you do in that situation? Now, not a lot of people do that, but I will tell you, people that get second opinions do. And the people that have multiple family members do. Are you getting biomarkers? What are you going to do with that lymph node? Are you going to do, right? There's quality metrics now. Surgeons are supposed to get a certain amount of lymph nodes, right, in with your surgery. And not everybody does that. And so the more lymph nodes, generally the better. But I guess what I'm getting is that's hard, but you as a patient, and I know you two both, that you will do this, but you're right. This is for other people. You ask the right questions, right? You did, I remember. Like, you're asking those detailed questions, and you will get out. If you don't get out of your surgeon or your medical oncologist those detailed questions, I mean, that's me. I would be like, I'm out of there, right? But if you do get the questions, then you can decide how that feeling is, because but with surgery, there's so many different ways we can do it to treat the same thing that are probably going to be equivalent over 2 to 3 years based on the data, survival-wise recurrence. But I will tell you, there's a lot of subjectivity when we operate. And for those, that's why I bring my med students out here. I bring the students out here. They've been in the operating room with me and with others. It's very different in every different operating room, just like it's different for every medical oncologist.
Yeah, and I think, and I know, and Michelle can attest to this too, in talking with folks that call, because sometimes people will call us and saying, I got this opinion and I got this opinion. Which one should I do? And it's like, no. we're certainly not going to tell you which one to do, but we do kind of ask leading and guiding questions like, what are your goals of care? You know, have you considered what's the risk reward to you? Because it is very personal to everyone. Not everyone says, even not every, you know, stage 1 or 2 patient who is surgical says, I want that. They're like, yeah, zap me with a little bit of radiation and send me home. I don't want to go to the operating room. So that, even that is a very personal question. And I think it's about having conversations with your healthcare provider, with your goals of care, and what is your intention? What are you hoping to get out of this at the end? And that makes it a little bit easier
And I think
to make those
it's okay
decisions.
to ask your doctor also, why did you come up with this recommendation and why not this other? Like sometimes they'll tell you, well, you know, this is just my experience, or there's data, or, you know, whatever it is. And so that gives you a better sense, because sometimes there's not one right answer, right?
Yeah.
And there are going to be multiple choices. And I think we have to also just, you know, as Jeff pointed out, I mean, people can do just fine with all the different approaches. And so why would you pick one over the other?
Different opinions. Yeah, so I think the majority goal is trying to reduce the recurrency. Is that right? I think that's the goal. I mean, removal is one thing, but
That's survival, right?
Exactly.
Yeah.
The long term is reduce or terminate that. So that's why reducing the recurrency is the most important to us. Yeah.
And that's great, and I think you should ask when you're getting that opinion, what is my chance of long-term survival, and why is it better with this approach rather than that approach?
Wait, didn't you ask if you're going to live to 100? The gold standard.
No,
Anybody else before we close out with a quick recap? Yeah.
I have a question. Oh, you can hear me. Yes. As a family history, my grandpa, who's a heavy smoker, who diagnosed with stage 4 lung cancer, 1998, and then he did operations in China, so they opened his lung and say, oh, it's all black, and they put it back. And then he, that's what his experience. Of course, later on, my family history is another thing is my dad, a little over a decade ago, he actually non-smoking small cell lung cancer at age of 58. And then with a strong family history, as far as I know, I have some breast cancer genes. So probably I'm the higher risk of group people. So I have 2 questions. The first one, what are the signs or maybe early signs of lung cancer for this group of high-risk people should be especially vigilant for, as from the doctor point of view? And the second thing, and maybe you put some comments on how personalized medicine for lung cancer. I know it's changed a lot last decades. And then what's the future about it and how your comment on it?
All right, I'll answer 1. Dr. Doss will answer number 2. So lung cancer is essentially a silent disease when it's early. The majority don't have symptoms early. That's why we try to do lung cancer screening for 50 to 80-year-olds, 20-pack year smoking history, or you're a current smoker and you quit within 15 years. But again, that's only for that set criteria. But those are patients that are usually, the whole idea of screening is you're asymptomatic, you're not feeling anything. Okay? So with that being said, the majority are asymptomatic. Now, the most common symptom that you'll get if you do have early lung cancer, late lung cancer, is cough. But then guess what? There's so many other causes of coughs, right? Reflux, asthma, allergies, and post-nasal drip. Those are more common than early cancer. However, cough is still the most common symptom that you'll see. So it's not that if you have a cough right now, you need to go in and see a doctor and get a CT scan, right? But what we say for people like that are at higher risk, because I know what you're getting at, family history and all that, that is a higher risk, you're Asian female, non-smoker, all of that. If that persists and you have symptoms, then that is an indication to say, hey, or it's not getting better with inhaler. So those patients, I do recommend you should try to think about getting an imaging study if it's still not going away, because those are early signs. The most common is cough.
And I'll just mention there are efforts in the Bay Area. There's a number of different institutions that are conducting trials to try to expand screening for patients like yourself, where you're describing a family history, because we have the guidelines for patients who have smoked, but not for never smokers, but who have that family history. And so I think, stay tuned. I think there are opportunities to participate in clinical trials, and I do think we're going to have data in China and in a lot of the Asian countries where we see a higher incidence of EGFR lung cancers and never smokers, there are strategies that they're employing out there for screening to be able to pick up these tumors at an early stage in people who've never smoked. And I think we're trying to adopt some of those in the US. And then on the topic of personalized oncology, I mean, this is why kind of we do what we do in medical oncology and in thoracic in particular. We are really the paradigm for precision medicine because of the sequencing and the targeted drugs that we're now have available for our patients. And so that's just doing that is a huge thing. And then individualizing even further is to try to look at circulating tumor DNA levels. So doing blood tests in patients to see, can we detect the cancer early in a patient's blood before we see it on a scan? And can we intervene early and make a difference for that patient? And so those are things that we're still learning, and we're trying to come up with assays that are sensitive enough to pick up the cancer at such early stages. But I think we're going to get there, and I think there's a lot of excitement about this. So combining a blood test with a screening test, like a CT scan, I think there's a lot of interest in doing that and ongoing studies throughout our area and throughout really the world.
Just to tag on to the studies, so GO2 and Alchemy, the Adario Lung Cancer Medical Institute, and Dana-Farber are currently running a study called Inherit, looking at potential germline mutations in people with family histories of lung cancer. So we can absolutely, and you can participate remotely. So we'll talk to you about it afterwards and give you a little flyer.
Thank you. That's great.
Anybody else? No. All right. Well, Jeff shouted out those screening criteria. So thank you for doing that. And we are way past, and I want to make sure that we get these two who are incredibly busy off and running. But thank you both so much for coming and having this conversation.
Thank you.
I know how complicated it is. Those of you in the room, those of you watching live, those of you who will watch post live, don't hesitate to reach out with any questions you might have after this programming. If we can't answer them, we know who can. So please don't hesitate to reach out. I want to give a little bit of up next reminder. So our next Gathering Hope is August 12th. For those of you who might not be familiar with it, it happens exactly 1 week before the Living Room on Tuesdays at 11, Michelle, 11, Gathering Hope, 11 a.m. Pacific time. It's open to anyone, and it's really a peer-to-peer support session where Michelle moderates and people can come in and really talk about anything you want to talk about, learn from one another, share experiences, share lived experiences, and really hear from people who are walking the walk along with you. So that is the second Tuesday of every month at 11 a.m. Pacific. The next one is, like I said, on the 12th. And then the next Living Room is August 19th. And it tends to be a really popular Living Room, and it's about navigating lung health and pulmonary care. Quite often, people living with lung cancer do not have a pulmonologist on their team. And when we're thinking about lung cancer in particular, it is a lung disease. So it's always really smart to have a pulmonologist on your care team, someone that's looking after the general overall health of your lungs, your lung tissue, helping to support you through travel and altitude and all of those types of things. So Kyle Hogarth from Chicago is going to be coming out and having that conversation with us. And obviously, again, to our panelists, all of you here in the room, those of you watching live and post-live, the film crew for coming in, as always, hours before, to making sure the lighting's good and the sound is good so that all of you at home can hear all of this important information. And then, of course, our supporters, and I am going to have to look down at the list for this. And for those of you who are regulars, it's because it's a long list. And that makes us incredibly proud, but also thrilled because these folks recognize the value of this type of programming and information that we bring to the community here in the United States, but globally as well. So Abbvie, Amgen, AstraZeneca, Bayer, Boehringer, Ingelheim, Bristol Myers Squibb, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Novartis, Novocure, Regeneron, Takeda, Oncology. Thank you all so much for your support. And until next time, there is dessert for those of you in the room. Those of you watching from your own living rooms, I hope you have some dessert somewhere in your kitchen. Thank you all so much, and we'll see you next month.
So I'll be brave if you're brave. I'll be brave, but only if you're